Good evening. I'm Stacy Loeb. I'm one of the urologists here, and we're going to talk a bit about active surveillance and some of the marker tests. I apologize, I'm a little bit sick, but I didn't want to cancel on this program, so I will try to make it through, but I apologize for my voice. So I guess the audience response system isn't totally working, so maybe we can just do a show of hands if you're comfortable, or you don't have to respond. Has anyone been diagnosed with prostate cancer? Okay, quite a few people in the audience. And I guess mainly I was just wondering if anyone is actually on active surveillance at this time, if you're comfortable sharing. Just to get a sense of if we have some of the people who may be in this situation. Okay, okay, let's just start with a little bit of introduction. I don't know how familiar everyone is or not with the prostate cancer. The prostate is an organ that's only in men, and it's in really a tough location because it's so close to all these other organs that are so important for function, like the bladder, the urethra, the nerves that go to give erections, the rectum. The prostate is not needed to live. That's why we are able to remove it or radiate it and these types of things to treat prostate cancer without impairing our ability to live, and it makes this substance called PSA, prostate-specific antigen. It's specific to the prostate, but it's not specific to cancer. So many of you have definitely had PSA tests if you had prostate cancer. Prostate cancer is the most common non-cutaneous cancer, non-skin cancer in U.S. men, and the second leading cause of cancer death in men. This is where it's located. So this is the bladder, and then the urine comes out the bladder, actually runs through the urethra, through the middle of the prostate there, and down and out. So that's a little bit of anatomy for you. The main risk factors are age, race. African American men have a higher risk of prostate cancer and of aggressive prostate cancer. Family history also increased risk of prostate cancer, but not really of aggressive disease, actually. And having a high baseline PSA at a young age. That's something that we've done some research on, and if your PSA is higher in your 40s, you're more likely to develop significant prostate cancer in your lifetime. So that is something that's worth counseling younger men on getting PSA baseline. So PSA is the screening test and also the way that we monitor prostate cancer after it's diagnosed. It is higher in the bloodstream of men who have prostate cancer. That's how it was found to be a tumor marker. And usually higher levels correlate with the aggressiveness of the cancer. Of course, the problem being that PSA can also be elevated for other reasons other than cancer, including benign conditions like infection or enlargement of the prostate. And that's true even if you're on active surveillance, where, if it goes up, it isn't always because of the cancer. So all of this is the background and this whole controversy that has been going on about prostate cancer screening, where it is important because it does find cancers early. Prostate cancer usually has no symptoms at an early stage. Some men have urinary symptoms, but they're usually from enlarged prostate, which is a totally different process than prostate cancer. So the only way to find it early enough for cure is to do screening. And screening has been shown to reduce the amount of metastatic prostate cancer and prostate cancer death. But it's controversial because sometimes the PSA is elevated and you do a biopsy and there's no cancer, so it's not perfect because it can be elevated for these other reasons. And it leads to diagnosis of some tumors that are very low risk and probably would have never even caused the man any harm or symptoms in his lifetime had they not been picked up. So that's what the focus is now here of this concept of active surveillance, is if we determine that someone has a cancer that has such a good prognosis, maybe they don't have to have immediate treatment, and that way they can preserve quality of life for longer. So this is the concept here that before we had PSA, many more men were diagnosed with prostate cancer at an advanced stage because we just didn't have a marker. So there has been a huge reduction in prostate cancer death rates since we started doing PSA screening, actually more than a 40% reduction. So that's really excellent, and models have been done to estimate, well, how much of this reduction in the prostate mortality rates are actually from screening, because we also have new treatments and things like that, and they suggest that about 40 to 70% is from screening itself. But this is what we discussed as some of the problems with screening, that elevated PSA doesn't always mean cancer, and many cancers found through screening wouldn't have caused problems. So this concept of overdiagnosis leading to overtreatment, treatments having potential risks like erectile problems, leakage of urine, or incontinence. So one way of tackling these issues is to reduce the burden of overdiagnosis. So, if treatment had no side effects, then we wouldn't be so worried about it. People, if I went to the doctor today, for example, there's a chance I'd be given antibiotics, but I really think I just have a cold, so I probably don't need antibiotics. But they're given out rather freely because there's not that much side effects to doing that. Whereas with prostate cancer treatment, there is a higher risk of significant side effects, and so that's why, it is a more serious issue, and we want to make sure that the people who need treatment get treatment in time, but spare men who may not need treatment from having additional side effects. So the whole concept here is dissociating diagnosis from treatment. And what that means is that it used to just be automatic that everyone who was diagnosed with prostate cancer basically got treated unless they were, so old and sick that they couldn't withstand a treatment. But now we realize that some cancers actually can be safely observed, and even if you're fit and young and could have treatment, you may not need to. So this is a quote I like from one of my colleagues. He's a urologist at Vanderbilt. He said, "Treatment or non-treatment decisions can be made once a cancer is found, but not knowing about it in the first place surely burns bridges." So I agree with this sentiment. I think PSA screening gives you information, and if it's elevated, having a biopsy tells you what's going on. But each of these is a distinct decision point, and once someone is diagnosed with prostate cancer, that's another separate decision where we need to, again, consider each patient's individual factors and whether or not they actually need to have treatment for that cancer. So that's all of the setup for the history of how this idea came about. Now let's move on to prostate cancer treatment options so we can get into more of the details of active surveillance, particularly for those of you who already have made it to that stage of the process. So many different types of treatment possible for prostate cancer. There's surgery, which is called a radical prostatectomy. There's different types of radiation. One of it is these little radioactive seeds that are implanted, and there's also external radiation called external beam. There's some newer treatment options available, and even sometimes treating part of the prostate is something that's being investigated in some places using a freezing probe, which is called cryotherapy, or even some investigation into laser therapy, or just not having treatment right away, which really falls into two categories. And these terms are often used interchangeably, but they're not actually the same. So the definition of watchful waiting and active surveillance is different. This whole decision is a multidisciplinary approach. So usually people are diagnosed with prostate cancer by a urologist, and then depending on which of the treatments I showed on the previous slide, urologists are the ones who do surgery and will typically follow patients for active surveillance. Radiation therapists do radiation treatments, and for men with advanced disease, medical oncologists give chemotherapy. So this is, we all have some multidisciplinary clinics here. So I'll tell you a little bit more about how we risk stratify prostate cancer and some of the differences then between watchful waiting and active surveillance. So as I mentioned, some prostate cancers are life-threatening. Yes? That's my next slide, I think. So 1 minute. So some prostate cancers, it is still the second leading cause of cancer death. So there are cases that, are life-threatening, and by diagnosing them early, we do have a better chance of cure. And in fact, treatment can be very effective. We have several forms of treatment that I mentioned on the previous slide that can cure the cancer. Sometimes more than one treatment is needed over the course of time. But the problem is side effects, and many other cancers grow slowly and may not cause harm if they're left alone. The problem is we can't always tell between them, but we do try. So let me, we only have one slide till we get to your question. I'm sorry, so it was 2 slides away. So the ways that we usually do staging to try to help make a decision about these forms of treatment is through the PSA blood test. Higher levels usually mean higher risk. Clinical stage is what the exam felt like, so if there's a nodule or not on the exam and how extensive it is. The features of the biopsy, which is the Gleason score or the cancer grade. That is undergoing some changes at the moment, by the way. 6 has traditionally been the lowest, and it's funny kind of to have 6 out of 10 be the lowest that somebody could have. So I participated this year in a consensus conference with a group of pathologists, urologists, and medical oncologists from around the world, and it's going to be renamed. So Gleason 6 will be grade group 1. So now there will be 5 grade categories, and what has been known as Gleason 6 is going to be called grade group 1, which hopefully will help for future patients to grasp the scoring system better, since the scale actually starts at 1. Imaging studies are also sometimes used to help with staging. CAT scans and bone scans are sometimes used to rule out spread of the cancer. MRI can be used for that reason, or also to look at the prostate itself and see whether there's any kind of suspicious lesion in the prostate. And then there's some new marker tests, and that's something we're going to spend some time on in this lecture. Okay, so getting back to your question. So what is watchful waiting and what is active surveillance, and when would we use these tests? So watchful waiting was like the traditional wait and see approach, where the idea was never to give treatment. This is for patients who don't plan on receiving any kind of prostate cancer treatment at any point, and the goal is not to cure the cancer. The goal is that the patient wants to preserve their quality of life and will only have any form of treatment as a palliative measure if, for some reason, the cancer has progression and they experience pain or other symptoms. So if the cancer spreads to the bones and they have pain, then they would want pain medicine to preserve quality of life. Or if the cancer grows a lot locally, then they would have some kind of intervention done so that they could urinate or to relieve bleeding. So the goal here is not to cure the cancer or to follow it closely, because we're not planning to treat the cancer. We're only going to do any kind of treatment as a palliative measure if it advances to the point of symptoms. And it may never do that. So this approach is typically chosen by older men who have a lot of other health problems, where it's not expected that the prostate cancer would cause any kind of earlier mortality. And so their only goal is just to preserve their quality of life, and if it does cause any symptoms at some point, then to treat those. Whereas active surveillance is the opposite idea. The goal here is that the cancer may look very low risk now, and everything may look very favorable now, and therefore you don't want to get treated for it right now because it doesn't have any kind of bad features. But you do want to watch the cancer closely, because if it became more aggressive or developed any kind of worse features over time, then you would consider getting treatment for the cancer at that point. So this is active instead of waiting. The goal here is to actively follow the cancer so that if the grade goes up or it becomes higher volume where more of the biopsy specimen is involved, there would be the opportunity to intervene with the goal of hopefully trying to cure the cancer in a delayed fashion at the time that it's needed. Does that make sense, the distinction? Oh, okay, everyone else?
Help me a little bit with the timeline and history. The widespread PSA screening began when did the surveillance protocols?
Yeah, that's a great question. So PSA was discovered in the 1980s, and it was first approved in the late 1980s for monitoring men with prostate cancer. And then in 1991 was some of the first research published using it as a screening test for men without cancer to look for cancer. And it was officially FDA approved for screening in 1994. So that's the trajectory of PSA. My mentor, Dr. Catalona, led the first prospective study of prostate cancer screening in the US. So his initial publications of that were in 1991, and people were starting to use it then, and then the FDA official start was 1994. And active surveillance, the first program for that was initiated in 1995. And at that time, it was considered very investigational. And this is very interesting. Dr. Klotz in Canada started a program there. And if you look at some of the papers that he's written now, for the first 7 years, I believe it is, of the program, so up until, I guess, 2002, they had to do informed consent of men who were enrolling, where it was considered an experimental option. So just like any kind of research trial, in order to be involved in his active surveillance program, you had to do an informed consent form. And then after those first 7 years, it became, finally something that was accepted more within the community of doctors as a standard option. And at that point, they no longer had to do informed consent to be on the experimental protocol, because it had taken off as a real management option. But still, it wasn't utilized very much in the United States until really much more recently. There's some published data that as of 2009, less than 10% of U.S. men with low-risk prostate cancer were managed with active surveillance. In other countries, it started to take off much sooner. I've been doing a lot of work with Sweden, research on active surveillance with some collaborators in Sweden, and they have much higher rates there. In fact, now we're about to publish some new data that over 90% of low-risk, very low-risk patients in Sweden are on active surveillance now, over 90%. So they're really at the front edge of the curve on acceptance of non-interventional strategies. The U.S., the latest data are as of 2003. It looks like across different parts of the country, about 40 to 50% of low-risk patients are choosing active surveillance in this country as of 2003. So it does continue to increase, and I think the reason for that is because some of these protocols that had just started in the mid-1990s, only now are we starting to see some of the results, 10 and 15 years later, and see that many of the men are still on surveillance and still doing well. And that's allowed more doctors and more patients to feel comfortable with this approach. So that's the difference between watchful waiting and active surveillance in a strict sense of the definition. Many doctors actually even use these terms interchangeably, but they really aren't meant to be the same. But it is somewhat of a spectrum because some people get more testing than others, and the next part of my talk is going to be about some of the testing options during active surveillance. So how often is a second treatment needed? Active surveillance doesn't mean that you necessarily will never have prostate cancer treatment. The idea is to hopefully avoid it or at least delay it so that you have more years of life with preserving quality of life. So, a ballpark estimate, and these are averages based on different studies, is that, about a third of the people will have some additional treatment within 3 years. Sometimes it's lower, and I think this is going down because people are becoming more accepting of the strategy, because in our studies, actually, a fifth of the men stopped surveillance just because they chose to, due to anxiety or family pressure or other reasons without any kind of test showing anything wrong. So as people become more comfortable that this is, a safe approach, if the cancer is staying stable, hopefully this is even going to be lower. In some of the studies from Hopkins, people went an average of 8 years on active surveillance. So many of the men ultimately got some form of treatment, but they still had 8 years free from treatment-related side effects. So I think instead of thinking of that as failing surveillance, you could think of that as success, that they were able to delay it a number of years. How common is prostate cancer death on active surveillance? Actually, it's pretty rare. It's probably even less than 1 out of 100 people. There's 2 big studies, Johns Hopkins active surveillance program and the Toronto program that I mentioned, and both have had very few prostate cancer deaths. Okay, so pros and cons of watchful waiting. So we talked about this earlier. There's no, the goal isn't to cure the cancer. So the cancer isn't cured. The cancer is there. It can spread. It can grow locally within the prostate, which could block the flow of urine, cause things like blood in the urine, or cause death. The pros are that there's no side effects, and even it minimizes the burden of doing all these repeat tests, because anyone on active surveillance would know that they are going to end up with additional biopsies. And watchful waiting, you would not do additional biopsies of the prostate because we're not planning to do any treatment of the cancer. So we're not looking for the grade or anything else. It only matters if the patient has symptoms. So, but it may never cause any problem at all in their lifetime, and they have made it through the process with the least possible side effects or burden. Active surveillance, it still has fewer side effects than full treatment, but it is a more active and involved process than watchful waiting. Nevertheless, the cancer still may not cause a problem, just like watchful waiting, and you may still find it in time for cure. So if it gets worse, you can get treatment usually at a later time. The cons are, you do have to follow up with repeat testing. So this means, going to doctor's visits, risks of biopsy again. There is a small chance that the cancer could progress in between tests and that you would not find it in time for cure. So, and as with watchful waiting, that it could spread or cause death, although what I mentioned is that in the long-term studies that we have now, that risk is very low for well-selected patients. So this is just a list that I brainstormed of what I think are important to think about, because, these are preference-sensitive decisions, and my patients span quite a wide range in terms of how much intervention or not intervention they're comfortable with. I have patients who say that I do not want a biopsy or anything done to me unless I absolutely have to. I am very happy with my quality of life. If my life ended sooner, but I have good sexual function and can travel and do everything I'm doing just as I am now until the very end, that's what I want to do. And so there's people at that end of the spectrum, and even my dad is probably more at the opposite end of the spectrum. I think if he was diagnosed with prostate cancer, he would prefer to just have surgery done, have it out, and move on and not have to do a lot of testing. So I think there's various acceptances for following up frequently for testing, how much you care about getting the cancer out versus the risk of side effects, things like that. So, how anxious are you about the cancer? Many of my patients, if they find out that they have a very small Gleason 6 cancer, they're not very anxious because they recognize that the prognosis is very good. Other people are just more anxious naturally, and it would be difficult for them to live with knowing that they have cancer. And for them, it's possible that active surveillance is not the best approach. How well do you cope with not being sure? How easy is it to go to the doctor and do these follow-up tests? Would you ever consider treatment? There's only a point to doing things like biopsies if the information that's provided would change what you do. So I always try to reevaluate these things with patients before we do the next test, just making sure that the results of the test would actually lead to a potential change in management. What side effects are the most scary? Is it erections that are the biggest priority, or something else? And what is more important? This is a difficult question, but somewhat fundamental. Long life or quality of life? The most quality of life of all is probably watchful waiting for someone with a very low risk cancer, because then they're not burdened with testing or with treatment. But that would have, higher risks of progression and isn't really, the favored approach for young men with a long life expectancy. So these are just some things to think about in your own mind as you try to evaluate what you want. Okay, so now we're just going to assume that one has already chosen active surveillance and talk about some of the tests. So unfortunately, we still do have some reliance on repeat prostate biopsies as a method of monitoring the status of the cancer. But biopsies are obviously an invasive procedure. For those of you who have prostate cancer, you've had one. At the very least, it's definitely not something fun that people want to do, and at the very worst, it could have a serious infection result from the biopsy. So this is actually what we most are working on, I would say, on the research side of things. I think the holy grail is finding a way that we can monitor the cancer reliably without having to do biopsies, or to minimize the number and frequency of biopsies the most. So what everyone wants is the perfect set of non-invasive tests that could substitute for these biopsies. So we are not there yet, but we do have some progress, and I'll tell you about some of the markers and imaging that we're working on. So other tests, biopsy is the only way that you have the cancer in front of you under the microscope. And even some of the tests that some of the new tests use biopsy tissue to look at genomics, or like the genetics of the tumor. But in order to do that, you still have to have the tumor tissue obtained from a biopsy. So really the best thing that we would want are things like blood or urine tests or imaging, where you don't have to go in and get a tissue sample. Other testing options, we do serial tests of PSA and prostate exams for men who are on active surveillance. MRI is emerging as a new option, as a way to take pictures and look at what's happening in the prostate. And then there's some other new markers. So let's just talk about each of these, okay? So first is biopsy. So this is what gives you the tissue sample to see the actual pattern under the microscope. Is the cancer getting worse? Has the grade changed? Is it comprising more biopsy cores now than it was before? The cons are it's just painful with having needles going through the rectum. It requires you to go to the doctor and takes time, maybe a day off of work for those who are working at this time, and can have side effects. And the main thing of concern is really the increased risk of infection as a result of antibiotic resistance. And this isn't the fault of the doctor, or everyone gets antibiotics for prostate biopsy, 100% of the people. So it's not that the doctor isn't trying their best to prevent it. It's just that we do have, unfortunately, a big problem in this country and actually worldwide with antibiotic resistance because of people like me getting antibiotics for a common cold, because it's in the food. So, the meat and the fish that we eat, a lot of them have had antibiotic treatment. So people just harbor antibiotic-resistant bacteria in their body. So that can be introduced through a biopsy. But there are some ways to try to make the biopsies have less risks. One option is to actually take a culture swab of the rectum before the biopsy is done to check if there's resistant bacteria. And if there are, then a different kind of antibiotics can be used. So that's something that you could ask your doctor about, or just giving 2 antibiotics instead of 1 for broader coverage. Also, many hospitals monitor antibiotic resistance patterns. We definitely do that at our hospitals, and sometimes switch out the type of antibiotics that we used based on the resistance in our community. So there's some different ways to try to make this less of an issue. But nevertheless, I feel confident in saying, and you can correct me if I'm wrong, that probably most of you who have had a biopsy would probably rather have some other test if it wasn't necessary to have it again. So this is what we're talking about here. About 3 out of 100 people will have an infection with the biopsy, but only 1 of them would have a serious infection enough to go to the hospital. But if you're that one person, that's pretty significant. And then there are other risks of biopsy. Most men will have at least a couple drops of blood in the urine or the semen, the poop. This is usually mild and goes away on its own, but it can be off-putting. In particular, I have a lot of patients who are displeased about the blood in the ejaculate, and that can lead to some issues with their sexual function transiently. Again, that goes away. PSA, blood test. Of course, this is cheap and easy. You don't have to go see your urologist. This can be done anywhere. And it may help give an idea that the cancer is becoming more aggressive. The problem is it's just not always accurate. This is something that we also did some research on when I was doing my training at Hopkins, where we looked at how much the PSA changed over the past year of active surveillance, and then looked at what the results of the biopsy were. And so did the men whose PSA rose have worse features on the next biopsy? And if the PSA stayed the same, did the biopsy stay the same? And unfortunately, we found that the correlation was not very good. That is to say, if it went up, it didn't always mean that the cancer got worse. Sometimes the PSA went up and they still had small volume Gleason 6 prostate cancer. And sometimes the PSA did not go up and the patient's next biopsy showed Gleason 7 prostate cancer. So we were hoping that we could define some amount of change in PSA that would allow us to determine that the cancer was becoming more aggressive or was not becoming more aggressive without having to do that repeat biopsy. But we were not able to define a specific change that was a sure bet. So yes, it's a helpful indicator, and certainly if it went up a lot, it should trigger some further investigation of some kind. But unfortunately, PSA by itself and its changes haven't been enough to avoid us doing repeat biopsies. Prostate exams, again, I mean, this is fairly simple. This is something patients don't usually love either, and it does require you to go to the doctor to do. And it's cheap, it's simple, and if there's a large nodule, then that could clue you in that the cancer is getting worse. But in my personal experience and of many of my colleagues who are prostate cancer experts around the country, and we've been interviewing a lot of them recently for a research study, experts on active surveillance, we have seen very few patients ever who progressed on active surveillance that was discovered as a result of a change in rectal exam. So I would say that this is very unusual, that this would be the way that progression is discovered, because usually these are very small tumors, and if it changes from a Gleason 6 to a Gleason 7, that is not associated with a change in the rectal exam. So it's worth doing because it's cheap, and the doctor should be checking it as part of their exam once a year, but this is not alone going to be sufficient for active surveillance. MRI, this is another new option to come down the pipeline in the last, I'd say, 5 years or so. It's really hit the prime time. What's nice is it's not invasive, and you do get good quality pictures. Very important to go somewhere with a big MRI program because it is user dependent. So not all places are good at prostate MRI. It is something that requires expertise, unlike some other types of imaging. So I would just be aware of that and make sure that you're going to somewhere that has a well-developed prostate MRI program. And these pictures can show that the cancer is becoming more aggressive. So there's now a growing number of studies showing if you can see a suspicious lesion, and MRIs are scored on the PIRADS is the name of their scoring system. It's a score of 1 to 5. 1 is the lowest suspicion, and 5 is the highest. So, people with a score of 4 or 5 on a prostate spot in the prostate that's seen on an MRI, they're more likely to have a significant cancer. So if you see something like that, that could be a clue that there is something more aggressive present there for a man who is either thinking about active surveillance or on surveillance. The cons, MRI, you're sitting in this noisy machine, so it's also not the most fun, and it does take up some time. It misses some cancers. The cancers that it misses, though, are more likely to be small, low-grade tumors. So the good news is it's less likely to miss an aggressive, large cancer. But typically, if we see a change in the picture, still that would lead us to then do a biopsy to see whether it was really had increased in grade or volume. So MRI is definitely an option, and it can be used to target the biopsy. So that's what's nice, because, if the PSA changes a lot, and then you say, okay, well, the PSA shot up, we should do another biopsy, but it doesn't give you a map. You don't know where that PSA rise is coming from, whereas if you have an MRI, and there's an area that's growing or looks worse, that is something that not only tells you need a biopsy, but it also can give a roadmap where we should focus in the biopsy. So that is another advantage to MRI. Then we've got some new marker tests. So the Prostate Health Index is the first one. We did have an education program on that several months back. Were any of you guys at that one? No? Okay. So this is a blood test, actually. It's kind of like a new and improved version of PSA, actually, that contains PSA. So it's PSA. Has anyone in the audience had free PSA checked before? Okay. Yep. So free PSA is kind of a different form of PSA that has been around since the early 1990s. And then there's this new one called Pro PSA. So I'm just going to show you a little diagram in a second of what these are for those who are interested in more information. But this prostate health index combo test of these three forms of PSA was approved in 2012 for men who don't have cancer as a way to decide on biopsy in the first place. And since it was FDA approved for that, people looked, well, what about checking it during active surveillance? Again, this has been shown to predict progression during active surveillance. So this is kind of what it looks like here. PSA in your blood can circulate around in the bloodstream in two forms. Some of it is bound to proteins. So this is called complexed PSA, where it's attached to proteins. And then the other part of it is free PSA. And these fractions may differ in different people, but the free PSA, so this is all that we knew about. This, this half of the diagram is what we knew throughout the 1990s. And it's only more recently that we discovered that actually there's all these different subforms. So this prostate health index checks this subform and this one and this one. So it's just combining three different forms to give a better idea of whether aggressive prostate cancer is present. So just to give you a better idea of what this looks like, so you get it back. It has the PSA, the Pro PSA, and the free PSA results separately, so all these three forms. And then they use a mathematical formula to give a combined score. So then it tells you the risk of prostate cancer. So this is designed for somebody who doesn't have prostate cancer to tell them the risk of finding cancer on a biopsy. Here's another example. This patient had a PSA of 4.4, which is in the gray zone. Free PSA of 21, which is pretty unconcerning, but actually the Pro was very high. So the combined score is very concerning, much more so than any of these individual numbers would have been. So that's going to be available in New York State within the next couple of months. And that's something that those of you who are on surveillance could ask about to get it for monitoring instead of PSA, because you would still get PSA, but then you get these other forms that are a little bit better. The next test that I get asked about a lot by patients is PCA3. This is a urine test that's been around for several years now, and similar to the prostate health index, it was initially tested for men without prostate cancer. And it was found to be helpful for men who had a negative biopsy to help decide if they should have another biopsy or not. Unfortunately, this one has also been tested in active surveillance and did not do a good job of predicting progression. So this seems to be an indicator that there is a cancer there, but it doesn't correlate well in a lot of the studies with the aggressiveness of the cancer. So in active surveillance, we already know that cancer's there, so that's not the question. What we're wondering is there aggressive cancer? So we just need to make sure we're using tests that show aggressive cancer. Prolaris. Now we're moving gears. So prostate health index was a blood test. PCA3 is a urine test. This is a tissue test. So you have to have a biopsy in order to check the tissue for Prolaris. But this is actually looking at the genetics of the tumor with these cell cycle progression genes. So that sounds very complicated, but it's just looking how much are the cells proliferating. So they take the biopsy tissue, send it off to this laboratory, and they tell you, you are thought to be low risk, but actually the tumor is having a lot of proliferation in the tissue. So you may actually be higher risk than was suspected. So this test has been looked at in a bunch of different studies. One study was of men having watchful waiting, actually, in the UK in the 1990s. And so they followed them through and said that this test predicted which ones ended up dying from prostate cancer. So that's what they report back. So if you have your biopsy sent for Prolaris, what the doctor gets back, they put in all your information and they look for these proliferation genes under the microscope, and then the report says, what is the 10-year risk of prostate cancer death without treatment? So in this particular case, it was 1%. So this patient may decide, I have an exceedingly low risk of dying from prostate cancer in the next 10 years without any treatment. So this could be helpful for this patient to feel more comfortable. But if it was much higher, perhaps they would be more concerned about not treating the cancer. So this is currently available, and in some cases can provide additional information for men who are considering surveillance. What's being studied now is looking at this on a serial basis. So could we look at Prolaris from biopsies during surveillance? And if the score is going up, is that a way that we could decide who needs to come off surveillance? So that's being studied now. And the other test that's in the similar space is called Oncotype DX. These are like competing tests because they both are with the biopsy tissue. So again, just like Prolaris, you send the biopsy tissue to the company. Well, you don't, your doctor would request it and the pathology lab would send out the tissue to this company, which is a different company than the other one. And they're also checking genes within the tumor to see if the tumor is acting more aggressive, but it's a totally different set of genes than the Prolaris test. And this one has also been shown to predict the risk of bad acting cancer. So what they did in the studies of this one is they took men who had low risk or intermediate risk prostate cancer who decided to have surgery. They decided not to do surveillance, and they said, did the Oncotype DX predict which ones had higher risk cancer at surgery than we thought from their biopsy? And this did help to predict which men ended up having worse pathology found at surgery. And so therefore, had they chosen active surveillance, some of them would have been the people who progressed on active surveillance. So maybe we could help to select patients better by getting one of these types of tests at the beginning. So this is what the report looks like here. So in this case, you have what was the patient's risk group before they got the test. Were they very low risk, or intermediate risk? So this is where the score is. This is the score. Oncotype DX score is called GPS, Genomic Prostate Score. So based on this Oncotype DX score, the likelihood that this patient has favorable pathology at surgery. So it's a little bit of a different outcome than the Prolaris test that I showed you before, and that may help to make the decision on which test of these you would want if you're interested, because this is an area of controversy for doctors, actually. Like when I give a lecture on these at urologist conferences, I say that we have no idea which is better because they've never been compared head-to-head. So both of them take the biopsy tissue and look at gene pathways that indicate that the cancer is more aggressive, but I don't know which set of genes is better. But they're very expensive tests. So I think some insurance companies are starting to cover some of these tests, but it's something I would definitely check on because they're over $3,000 the actual performance of the test. So you definitely would not want to find out that you were responsible for any more money than you were planning. But like I said, I believe that at least one of these has been, or maybe both have been approved by Medicare. So hopefully many people could get coverage. But which one you would choose might depend somewhat on which piece of information is more of interest. Is the 10-year risk of prostate cancer death without treatment what you would want on the report? Or do you want to know if you had surgery, how likely is it that your cancer would be exactly the same as we predict on the biopsy? And so the first one would be Prolaris, and the second one would be the Oncotype DX. So these are both available, and right now they're mostly being used to help decide on treatment initially, but they could certainly be sent on a later biopsy also to see if we're staging it appropriately. I would say at least 30% of the time. This measures the actual genes in the tumor tissue. So when we stage it now, we look at the Gleason score, like the pattern of the architecture of the cancer under the microscope. A nice analogy, I don't have like a board to draw on, but think of donuts from Dunkin' Donuts, okay? So if you buy a box of donuts that we're going to share with the group, and that's Gleason 6 prostate cancer. There are these nice circular glands that look like a bunch of donuts. And now let's say I take the bus and it's really crowded and people bump into my donuts, and so now a few of them get smushed. So there's some that are still nice circles, but some of them have gotten a little bit mushed. That would be like a pattern 4, so that's like a Gleason 7. And let's say now somebody sits on the box and stamps on it, and now they're just a bunch of crumbs and you can't even tell that they were ever in the shape of a donut. That would be like a pattern 5, like a Gleason 10. So what we look at is just the way that the glands look, which is, it's definitely predicts the risk of aggressive cancer and of cancer death, but you could imagine that that's not the most refined. So what these tests are doing is looking at actual genetic behavior of the cancer cells instead of just the way that the architecture of the tissue looks. And the reason why this idea came about is mostly just the undersampling issue of a biopsy. The way that I describe this to my patients is that think of an apple, okay? Your prostate is an apple, and there's a little rotten spot in the middle of the apple somewhere. That's the cancer, just a tiny brown area in the middle there. So if I take a needle and stick it in the apple 12 times, if the spot is very small, maybe one of the 12 needles will hit it, but maybe it won't. So, think of sticking a needle in an apple. It only samples about 1,000th of the prostate biopsy. Now, if you have an MRI first, and the MRI shows a suspicious lesion, and your urologist does a targeted biopsy, where they do take some specific targeted cores of that lesion, then it is more likely to be higher yield. So that's definitely something that the field is moving towards, is incorporating these targeted biopsies. But even that technology is still not perfect, making sure that we accurately target the lesion perfectly. These are also an objective way to check under, how are these genomic pathways within the tumor actually working, which doesn't depend so much on the pathologist's reading of the tissue. So it's a way to give more information and combat this sampling problem. Okay, so I'm going to have to conclude there, but the summary is that screening does reduce advanced disease and prostate cancer death, but leads to overdiagnosis. So an important way for us to reduce the harms of this is by expanding conservative management for appropriate patients, which would be low-risk cancers. Watchful waiting is the very most conservative approach, minimizing the amount of testing and burden with no goal of cure. Active surveillance is more active, but can still delay at least, or maybe avoid the need for radical treatment during the patient's lifetime. Biopsies are still an important component of active surveillance to check for increases in grade because changes in PSA are just not totally reliable. But the risks of infection with biopsy have increased, so important to mention any risk factors for infection to your doctor, like if you were recently on antibiotics for something else, or you recently traveled to Asia. That's actually also a risk factor for biopsy infections. So there are some new tests that may be helpful. The Prostate Health Index is coming soon to New York, and it actually already is available in the rest of the country. So if you live in somewhere else in the tri-state area, you may be able to get it. But New York State, frustratingly for me, has some extra regulatory process. So we've been the last in the entire country to get this test. And also MRI is another non-invasive way to try to keep tabs on what's happening with the cancer during active surveillance. And then these two tissue tests that I mentioned, Prolaris and Oncotype, may also help to just provide some more refined risk stratification. Is the cancer low risk like we think it is, or is it actually proliferating more at the cell level? So I think that is it. If you want more information, these are some sites that I like: the Prostate Cancer Foundation, the American Cancer Society. There's plenty of medical academic papers, and if anyone wants some specific references beyond this, let me know. And also, I'll just conclude by saying we actually are going to start to do some focus groups with patients on active surveillance. Erica is right here. She's going to be conducting this study pretty soon with me, where we want to actually design a website with more information on all these tests for patients to use, or to provide the types of information that men on active surveillance need. But I'm not a man on active surveillance, and every patient has different needs. So what we are going to be doing is doing some groups to see what kinds of information would be most helpful. So hopefully that's something that down the road, though, that we will have more tools out there with more of this information readily available from anywhere in the world. So you're welcome to talk to either of us if you want more information. All right, thanks. Yes.
How do men feel about being treated by a woman doctor? And one follow-up to that, how many men who come in with their wives actually choose either active surveillance or watchful waiting?
That's an interesting question. So the first one, it depends on the culture, I think, in terms of response to females. I mean, definitely we are a minority within the field of urology. There was a study in 2014 that only 8% of board-certified urologists were women, and almost all of them were in pediatrics or female urology. So, I mean, I'm like almost virtually always the only girl at the prostate cancer meetings that I go to. But then again, I'm like teaching all these male urologists about these tests and fielding questions on how to manage the patients. So ultimately, I think in the U.S. culture, fortunately, most men are just, especially with something like a prostate cancer diagnosis, their main concern is who has the most knowledge and expertise on my condition. and it's less important, your demographic or what you look like. But definitely, I have had patients from certain cultures where they are less comfortable with female physicians in general. But that's okay. Hopefully, as our society progresses, and what percent that come with their wives. It's interesting because there have been some studies to suggest that adherence with active surveillance may be better in married men or men who just have more support in general in order to stick with the process. On the other hand, I have noticed, and we've gotten responses from other physicians through our studies saying that sometimes it's the family members who are trying to talk the man out of doing surveillance because they're worried about him not having treatment. So I think that was actually one of the other rationales for why we thought something like a website with more information might be nice, because that's something that could be shared with the family. And hopefully, if more data are presented to the wives and the children of the patient, that could help make them more comfortable with this as a decision, that it wouldn't be a barrier, and that they could be champions for it. Do the 2 pro-PSA used in the PHI made exclusively by the cancer cells, or is it made by all prostate cells? If so, has there been a study comparing tissue taken from tumor, BPH, inflamed, and normal to see whether the other conditions can also raise the 2 pro-PSA? Yep, that's a great question. So actually, yes. So the pro-PSA is more specific for cancer than the total PSA. So that's why, so it's less likely to be elevated in BPH. In fact, I don't know if it's still available, but if we go back to that chart, one of these other forms, here we go. Okay. Yes, so this one. So if you look at this chart, now that we have a better understanding of all the different forms of PSA, this one, BPSA, is elevated more in BPH, whereas PRO was named PRO because it's more specific for prostate cancer. So no, it's also not perfect, but it's better than looking at the whole thing, and it's better than looking at just the free, because we're able to rule out this part, the BPH PSA portion. Do I think we've found the golden bullet with any of these tests? No, I think we still have work to do, but why not try to use the best tests that are currently available? So definitely, as soon as I'm able to order this is going to be incorporated into my active surveillance protocols for patients. I said it will be available in New York. Is that for both screening and active surveillance? Yes. The doctor could order it for any reason that they want to. The FDA approval was for screening, but that doesn't, some of the other tests are not even FDA approved. So they can be sent still for other indications.
What are the risks of the repeat biopsies itself the cause of the cancer spread?
Oh, that's actually not a big concern. On the contrary, in many cases on active surveillance, repeat biopsies will come back completely negative because the cancer was so small that it isn't even picked up on the next round of needles. So there's really not a concern about needles spreading cancer. Interestingly, that is something that I get asked by patients a lot, but the medical literature has not borne that out.
I'm thinking that because of the blood that is causing the bleeding.
Yeah, nope. That's not something that is thought to be a risk. In fact, men who have had more repeat biopsies are more likely to have an indolent cancer. So if the biopsies were causing the cancer to get worse, you'd expect it would be the other way around. Yep. The main concern, though, again, is infection. So we studied whether men having a repeat biopsy have a higher risk of infection, and they don't. The repeat biopsy was the same amount of risk as the initial biopsy, but the more you have, the more times you're faced with that risk. So if you're standing in the same spot on the beach and lightning strikes, if you're there for 50 summers, then there's more risk you would get hit one of those times than if you were there once. So that was kind of the analogy that my collaborator made about this. And then there's a theoretical risk, and we're not sure about this, but that one theoretical risk is whether it could harm erections by having multiple repeat biopsies, by causing inflammation around the prostate. So the evidence is still out on that one, whether or not that is an issue, but it's something I think is worth patients knowing is under debate, because many men choose active surveillance to avoid erectile problems. So I think it is relevant to be aware that there is a possible theoretical concern that having many biopsies could reduce erections.
Yes, you mentioned that the two-probe PSA is negative, a cancer indicator, so that if you find any two-probe PSA, you know there's cancer.
No, it's not perfect. It's just more specific for cancer.
In other words, you could have two-probe PSA and not have.
Well, that's why they relate all of those in a ratio with the prostate health index. So it's a formula that is how much of the free PSA is pro and how much is free compared to total. And it gives a ratio that compares those three to each other to give a better idea of, does this particular relative concentration something that's more suspicious? So again, this still is not a 100% indicator. They named it pro because it's more closely related to cancer, but it's not perfect. But by taking all of them into consideration is better than just looking at the whole of PSA.
Theoretically, you could have PSA, free PSA, and even two-probe PSA, and theoretically still not have cancer.
Yep, nothing is 100% that we have in our paradigm at the moment.
One more question.
The tissue test that you described, they give it the genetics.
Yes, Prolaris and Oncotype.
That's new to prostate cancer, right?
Yes,
And it's common in other types.
that's right. Actually, some of these have breast cancer and colon cancer tests within their company.
So why at the genetic level and the genetics of the why is prostate cancer kind of behind the curve?
Great question. I think, probably because it is so heterogeneous. I mean, such a wide spectrum. Why did it take so long for these tests to come out compared to those other cancers? I mean, I have no idea. I don't do any research on breast or colon cancer, so I don't know, what the development process was of those. But yeah, these have only been around for the last couple of years. And I mean, Oncotype, the first published study didn't actually come out in a journal, I think, until 2014. And then within the year, the second validation. So, this is all just coming forth. And we don't even have published data yet on how to use them serially. So what I'm most excited for is to see what happens with changes in these tests over time. So especially now that some of these insurers are starting to cover them, and so they could be tested more, it will be interesting to see if the score increases. Is that a better indicator of who, has an aggressive cancer? And could that be used to decide how long we can wait till the next biopsy? So, could all of these help together? Could the prostate health index be the blood test? And if that goes up, then you get an MRI. And then if that's concerning, you get a biopsy, and the biopsy gets tested for these. You know, I think with this movement towards precision medicine overall, hopefully we can do a better job of using some of the new markers and using new things like genetics to say, you know, your tumor is just slightly more aggressive than other people like you, or it's less aggressive, so that you could make a better decision than with the somewhat crude tools that have been available up until recently.